Good afternoon and good evening, and thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are glad to welcome back His Excellency Dr. Jean Kaseya, the Director General of Africa CDC, and we are also honored to have with us Dr. Austin Dembi, the Minister of Health from Sierra Leone. I will now hand over the floor to Dr. Kaseya to start the session. Over to you, DG.
Thank you so much, Margaret. Good morning, good afternoon, good evening to all of our colleagues who are joining us. Today, we have the opportunity to have Minister Austin Dembi, who's a champion, a person who managed to respond to a terrible Mpox outbreak. And today we are celebrating the success of Sierra Leone, and he will have opportunity to share with us some thought how he managed to do that and what are lessons learned. Let us start quickly with the presentation, then we'll go to Minister Dembi. Margaret, back to you for the presentation. I'm taking this call from Abuja. I landed this morning in Abuja, coming from London. Next slide. Coming from London where I had a number of high-level meetings. But before London, I was in South Africa for the G20 meeting and also the EU-AU high-level health meeting. You know, the G20 meeting was an opportunity for us to discuss with our partners on the vision that we have for Africa. And this vision is mostly built around health, security, and sovereignty of our continent. Next slide, please. Then from Monday to yesterday, I was in London meeting senior officials from the UK government, including Baroness Chapman, who's the Minister of Africa and International Development. And we had opportunity to discuss with colleagues from the UK Minister of Defense, UK Health Security Agency, Department for Environment, Food and Rural Affairs, and also the FCDO colleagues. And we had this co-creation meeting on the way they have to support the vision that we have for the continent. And we signed an ambitious MOU to show the collaboration that we have with the UK agencies. Next slide. When we are talking about outbreak preparedness and response, lab is playing a major role. As you can see, around 200 colleagues coming from everywhere in Africa. They are attending this symposium on resilient diagnostics and genomics surveillance for health security in a shifting funding landscape. And in his past, Minister Dembi was also a lab guru. Maybe when there are questions around this meeting, it will also help us to get some background on where we came from and where we are going. Next slide. There will be a number of articles in the Lancet. A few days ago, we had this one released by my colleagues, Dr. Ngashi, Tajudin, Shadel, and Yap, on the Africa leads multilateral health organization support. We are mostly talking about the reform of the global health architecture, and we believe that Africa is really leading now this agenda. And the next what you will see that will come on Monday, save the date, track the Lancet, it will be the new vision for Africa, moving from new public health fodder to Africa helps security and sovereignty. I'm already sharing with you. And you see the 5 pillars. The first one is about local manufacturing and African pool procurement mechanism supported by African Medicine Agency. The second one is about sustainable health financing with a major component on community-based health insurance scheme. The third one is about the digital transformation agenda. The fourth one is about PPPR, pandemic preparedness, prevention and response. And the last one is talking about the reform of the global health architecture with a clear message. Countries are leading, regions are coordinating, global is supporting. That one is joining this Lancet article that was released on the 8th of November by my colleagues. And what you will see on Monday will be the vision that is replacing the new public health order. Next slide, please. Yes, it's an opportunity for us to discuss a number of development at continental level. We still have Mpox, but you see, even if there is decline, we still have cholera. You will see, we'll talk after this slide about the new public health event, that is the hemorrhagic fever in Ethiopia. And all of that, the team working with all partners under the leadership of member states, we are responding efficiently on these outbreaks. Next slide. Yes, when we talk about the viral hemorrhagic fever in Ethiopia, it was released yesterday, and we thank the government of Ethiopia for the transparency and the quick action that they took. Currently, we know that this event is in what we call the Omo region, and the capital is Jinka, not so far from South Sudan. We have 8 suspected cases, and the genomic sequencing is ongoing. We want to know what is it, this viral hemorrhagic fever. I think we'll have the result by Friday, Saturday. I'm flying back to Addis to be with the minister and to work on that and to make sure that we have appropriate action. And but in the meantime, we started to take the needed actions for this kind of outbreak, sending appropriate people on the ground, supporting the case management, and collecting and sending to Addis Ababa needed samples for confirmation, and also supporting the community with the risk communication and community engagement approach. Next slide, please. We are still crossing our fingers for the Ebola outbreak in Bulape in DRC. I hope to be in Sierra Leone and in DRC to celebrate end of the Mpox in Sierra Leone and end of Ebola outbreak in DRC in the next 16 days if we don't have any new case. For now, I think we didn't have a case for the past almost 30 days, and we believe that we can continue like that. Next slide. Yes, the general trend for Mpox is the decrease, as you can see, from epidemiologic week 43 and to the week 44, there is a decrease in terms of suspected cases, confirmed cases, and also the general trend, as you can see, is really the decline. And we didn't have any confirmed cases in Sierra Leone for the past 12 days. That is amazing. This is why we have today our champion, Minister Dembi, to share with us actions that he took. Next slide. The three countries where we are still following closely are Liberia. You can see we still have a number of cases in Liberia, Ghana, and Kenya. DRC, as you can see, there is a clear decline. If you compare the 5 weeks and the 5 previous weeks, you see a decline of 66% in terms of change. I think we are sustaining that, and you'll see even Sierra Leone, there is a huge change regarding the Mpox. Next slide. Liberia, even if we compare the 5 weeks with the previous 5 weeks, we see an increase. But if we compare week per week, the 44 and the 43, you will see the decrease in terms of cases, and we are glad that we didn't have any death for this period. We are still working closely with the government to contain the outbreak in Montserrado County, where we have the most of cases coming. And we are also working with the government to ensure that the challenge that we could have in terms of logistics can be managed for the country to start to vaccinate quickly, because out of 53,000 doses we provided, only 14% were used. Next slide. As you can see, Sierra Leone is a model. We had 173,633 people vaccinated, and we have the testing rate that is 100%. And we have, as you can see, a huge decrease. Confirmed cases, 0 for this week. If we compare to the previous week, that was 9. The same trend for the suspected cases. I think I will not talk a lot about that because the minister is here to lead us on what he did. Next slide. Vaccination, the key message we are getting here, first, Africans, they don't refuse vaccine. They like vaccine, and we are welcoming more doses. Second, African countries are working together with partners to ensure that we are using vaccines that we are making available. And as you can see, 16 countries already received vaccines, and 13 are vaccinating actively. And we believe that we can maintain this approach by also requesting to have more vaccine to stop this outbreak. We don't want to see the yo-yo like from Liberia, Kenya, and other places. Next slide. Cholera is still a major issue, but look, this slide is clearly saying that even if we are still in November, but we already had the 303,000 cholera cases compared to the 254,000 that we got in 2024. But if you see the trend from 2022 to 2025, it's like every year we have more and more cases. And the same trend is also regarding number of deaths, but also number of member states reporting. It means we need to really using the cholera plan that we launched in Zambia, we need to fully operationalize that to stop with this trend that we are seeing in Africa regarding cholera. Next slide. As you will see, we still have 2 countries, even if where we got more cases like DRC, like South Sudan, we see a decrease, but we still have some countries, Angola and Burundi, where we have, some changes in terms of number of cases and even number of deaths. Next slide. You will see that here, when we are talking about Burundi, if we compare the 5 weeks with the previous 5 weeks, yes, there is an increase, but if we compare the previous week and this week, we see a decline, but we need to sustain this decline. And the major challenge that we have there is the fragile water infrastructure, because as we know, without water, we cannot really control the outbreak. And we are working with the government to see how we can address these issues. Next slide. Angola, it's almost the same challenge. It's also the same analysis if we compare the 5 weeks, but in terms of this week and the previous week, yes, there is a decline, but we need to sustain this decline by addressing the root causes that we already identified and that are in this presentation. Next slide. Cholera in DRC, it's still a major issue. Now, as you know, they started to target all regions. They call that river regions. And we need to continue to follow up and to support DRC for this outbreak. Even if we see a slight decrease from last week to this week, but it's still a major concern, and the insecurity, displacement of population, all of that are not helping, in addition to lack of wash commodities. Next slide. In summary, Ebola, we are waiting to celebrate. Mpox, major decline. A country, Sierra Leone, that reported a number of deaths more than other countries except the DRC. We see the progress. Cholera, as we said, the trend is just increasing year per year, but we hope to see at country level, with implementation of the plan that we approved, to see a good progress. Let me stop there. And before going back to our colleagues, journalists, let me hand over to Minister Dembi to explain to us how he managed with this Mpox outbreak in Sierra Leone, and what could be the perspectives and what are lessons learned that you want to share with all of us. Over to you, Minister.
So thank you very much, DG Kase. It's indeed a real pleasure to join you today in this important ACDC continent-wide and global brief. I think we've come a long way. In Sierra Leone, we saw the first 2 cases of Mpox diagnosed in January of this year. And over the past 10 months, we have recorded a cumulative number of cases of up to about 5,442 from just 2 cases in January. I'm very pleased to say today, as we speak, at the peak of the outbreak in about May, we had close to 2,000 active cases spread in every district in the country. As we speak today, for the past 6 weeks, we've had 0 deaths. As we speak, For the last 17 days, we've got 0 number of cases in the whole country. As of yesterday, 9 of the 16 districts have not reported a single case for more than 42 days. So it gives us real hope that we are in the right trajectory. We're moving in the right direction. We believe that by the next couple of weeks, we'll be able to contain this outbreak. For me, it's a testament to country ownership, country leadership in creating a nimble partnership with the government leaders, with traditional leaders, with civil society, with our development partners and our technical partners, especially Africa CDC. We have been able to deploy vaccines. We have been able to deploy over just a large quantity of vaccines, first to our primary healthcare workers, the frontline healthcare workers. The frontline healthcare workers accounted for about 49% of the vaccines deployed. We've also had very active contact tracing and ring vaccination of every contact, and we were able to deploy about 49% of the vaccines in that space as well. So very science-driven, very active case finding, identifying cases, sequestering the cases and managing these cases for their own health, and at the same time, actively disrupting transmission. Again, it's a testament to all of us working together and putting actual P, capital P, in public health and ensuring that the public was the main partner in this kind of transformation. It's a lesson learned. It's hopefully a model for all of us to see that if African countries like Sierra Leone are empowered, are able to deploy their own resource and garner additional resources and strong partnerships, that we could contain an outbreak of this nature. For me, the important lesson here is that we understand this very well now, and what we want to do is to install systems. As we declare this ended in the next few weeks, we want to be able to ensure that we have inbuilt systems now that focuses on prevention, rapid response, and containment. Over to you.
Thank you so much, Minister. I think you made it so eloquently. And we can really see that the person driving this response is a real captain who knows what he's talking about. Thank you, Excellency. I think our journalists are ready to squeeze us a little bit and to know more. Back to you, Margaret, for questions from journalists.
Well, just DJ, before you go on to the journalists, I just like to clarify, I am just a member of an incredible team. We had big support from the president himself. We had a really good team constituted of not only Ministry of Health, but the new National Public Health Agency. We had civil society. We had all the traditional leaders. We had the youth, and we had the Ministry of Health staff all working together to get the kind of results that we're seeing. It may be too early to celebrate, but I think we're moving in the very, very strong positive direction. Over.
Thank you. Margaret, back to you. Thank you.
Thank you, Honorable Minister. Thank you, DG. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. Thank you. Thank you, Dr. Kasie. Thank you, Dr. Dembi and the Africa CDC team. So my question goes to Dr. Dembi. I remember when you declared, this time around, we learned from our experience, everybody said so, from Ebola, COVID, we declared the national emergency immediately. I also remember at the time you warned that it could get worse before it gets better. And we saw that. So I want to know if where we got to, if that's exactly what you expected, I mean, the seriousness, I mean, we realize of the Mpox, if you expected it to get to that point. That's one part of the question. The other part is, I note already you have mentioned that we've learned a lesson, and you mentioned the need for institutional strengthening. Now, what is the one thing you, in hindsight, you could have done differently that you think, I mean, we could have at least seen a different experience than we did with Mpox? Thank you.
Margaret, do you want me to go ahead and
Yes.
answer that?
Go ahead. Yeah. Go ahead.
I thought those are really, really important questions. Again, one thing we learn in outbreak situations is it'd be very presumptuous to think that you know it all. We learn from every experience. I think for us, we found out that this virus has been in circulation, just circulating in the community at a very, very low level as far back as 2021. We also did recognize that, there are phylogenetic components of this virus that we still would like to better understand. We also realized that no matter what you do, the public, this is public health, the public is nearly as important as your biomedical interventions. And ensuring that the public understands what this is all about, and ensuring that the public appreciates the importance of it, and the public steps up to be strong partners with this service delivery partners. Until you do that, it's going to be very difficult to get the kinds of results that we saw. So in Sierra Leone, we've been through Ebola, you've been through COVID, we have Lassa. And so people have a perception of what a serious illness is and what a serious outbreak is. But the initial perception was, this is just a rash. This is a simple rash that you could manage. So it was very difficult to get the public to understand how serious this is, until we started seeing very dramatic cases where people's body parts were falling apart. And when that was made public, the public really understood the seriousness of this, and were able to rally around, because at the end of the day, when we say public health, everybody in the public should know what I could do to contribute to the solution. So the slow response there was more as a result of public perception of it. And, we were able to garner the vaccines needed. The government itself put about $1.2 million right off the bat, $1.7 million right off the bat of our own money to be able to respond to this. So I would say public perception was very, very important, and maybe we should have invested a lot more in bringing the public along. The second major issue there is with people's perception that this is a mild illness. The understanding is people will stay home for extended periods until they start having very, very severe symptoms before they show up in the hospital or clinic. And what happens then, you would have spread it to other people by the time you get to the hospital. And also the initial reaction was to treat people and give them health messages and health caution, and ask them to go back and maintain hand hygiene, social distancing, and give them all of the guidance that we're supposed to give, because we didn't want to overwhelm the hospital systems. Because we know from experience with Ebola and COVID, when you start admitting these patients into the hospital, people stop coming to the hospital. And as a result, all of the other services fall apart. So we thought that with a mild illness, you could diagnose and treat the person and give them good messages and let them go home and manage their illness, at the same time prevent transmission. What we learned in the middle of the outbreak was this did not work. And what worked was to identify the cases and extract them, remove them from the homes and the communities in which they are, provide high quality care, in a health facility, in a health environment. And at the same time, you inundate the space that they came from, the contacts that were there, with prevention messages and vaccines. So when we did that effectively, we saw that the cases were initially mounting, but when we changed strategy to actual bringing people into facilities and taking care of them, the numbers dropped precipitously. So in hindsight, if we were to do this again, every case that we see will bring them into the facility for their own care. At the same time, we'll prevent them transmitting it to others. Over.
Thank you very much, Honorable Minister. Let's take the next question. We have Janice from Bloomberg. Janice, you have the floor.
Hi, thank you. I am wondering if you could put a little bit of context on this news out from Ethiopia about hemorrhagic fever outbreak. I know that they are still testing to determine which disease it actually is, but you know, if you could give me any sense of the history or commonality in the region, and if there are any specific concerns considering where in the southern region it is, and you know, sort of the information Africa CDC is getting on that at the moment.
Thank you, Janice. DG?
Yes, Janice, as you made it, we want to name this viral hemorrhagic fever. This is why we are conducting this sequencing to know. And then based on that, we will see what are tools that are most appropriate to respond to that. Yes, Jinka is around 650 kilometers from Addis, but Jinka is almost, you know, bordering South Sudan. And we know that South Sudan is a fragile country with what is going on there. Now, with what we are doing, we'll identify where first this outbreak came from, if it came from somewhere, if there are some commonalities with previous outbreaks that we had. And we'll do what we did for Rwanda, to conduct all studies, to know what is the issue, where it came from, and how we can also prevent. In the meantime, our teams took a strong action to build capacities, you know, of South Sudan. We are providing support to Kenya, South Sudan, Uganda, Sudan, as we did during the Marburg outbreak in Rwanda. It's our action that we conducted to protect countries, neighboring countries, that supported Tanzania to declare a few months later this the outbreak also. I think this is what I can say for now. Yes, it's a concern because South Sudan is not far. Yes, we don't know what is it actually, but we are providing necessary support. And yes, also, once we identify what is the issue, we name that. Next week, the Minister of Ethiopia will sit with me, as we are doing with our other ministers, other leaders like Minister Dembi, to provide more information. Yes, back to you, Margaret.
Thank you, DG. Let's take the next question. We have Sarah from DVET. Sarah, you have the floor.
Thank you very much for taking my question. My question is for Minister Dembi. Is Sierra Leone currently negotiating with the U.S. government a bilateral agreement under the America First Global Health Strategy? If so, can you talk about what's included in the agreement? And is a pathogen sharing part of the agreement? And if so, what's the duration of that pathogen sharing agreement? And kind of more on a macro level, what are your thoughts on the new U.S. government's approach of bilateral agreements? Thank you very much.
Well, thank you very much, Sarah. We value the role of the U.S. and the U.S. resources in looking at our healthcare systems and responding to outbreaks of this nature. We quite look forward to the America First concept. We are awaiting a bilateral meeting between Sierra Leone and the US. That should happen anytime soon. And we look forward to very active engagement, focusing on mutually beneficial relationships between the US and Sierra Leone. Thank you.
And to support Minister Sarah, as you know, we first started with 16 countries, and there is a second round of other countries. I think, as Minister said, the second round, we are working to see the US coming to Sierra Leone. For now, I think Minister Dembi is not part of the first round. Minister, if I'm not wrong.
That's correct. I want to speak from a position of direct knowledge, and we've been told that the US, I mean, we had initial consultation before the actual strategy was launched, and now we're looking at the opportunity for its implementation. But for me, the bottom line is we welcome the new engagement. We look for opportunities, and again, it's built on a platform of mutual respect and mutual trust that looks to see what is in the best interest of the US, but also what's in the best interest of Sierra Leone. Thank you.
Yes, we said in Africa, we got a mandate, and we are talking with our colleagues from the US. We had the first meeting for the 16 countries almost 3 weeks ago, just to alert them. And now there is a team, or there are 3 teams, you know, moving around. After this visit, we'll have a call with countries we know from the second round and the first round and the second round, including Sierra Leone. We want the ministers who are, I'm like now in Nigeria, I have immediately after this press conference, a meeting with Minister Pate, who will debrief me on how it went, but we want ministers to talk. You know, our role, as Minister Dembi is saying, how can we have the best approach, the best deal based on mutual accountability and a respectful partnership? How can we have the best deal that African countries can conclude? And we are also repeating that the US is not the only partner in Africa. We have so many other partners. It means the countries, they must have the ownership, the leadership, bringing now all partners together, including the US. Back to you, Margaret.
Thank you, DG. Thank you, Honorable Minister. Let's take the next question. We have Rachel Abuja from Nigerian News Agency. This is a question for Dr. Kaseya. Dr. Kaseya, you highlighted Nigeria's progress with SWAP, digital payroll, and domestic resource mobilization. In your view, which of these interventions has the greatest potential to sustainably reduce out-of-pocket spending across Africa, and why? And then the second question there to you, Dr. Kaseya, is on the Lusaka agenda. So you spoke about the Lusaka agenda and requiring global partners to become Lusaka compliant. How do you see this approach influencing donor funding priorities across Africa? And what challenges do you anticipate in ensuring countries implement it effectively? Back to you, DG.
Yes, thank you so much. Today, during my opening remarks to the joint annual review of the health sector in Nigeria, I said we have mostly 3 main sources of health expenditure in Africa. And the first one is not ODA. The first one is out of pocket. We have countries where out of pocket is even representing 70% or more. It means poor people are paying while they don't have this, they don't have possibility to sustain that. SWAP is good, digital payroll is good, domestic resource mobilization is good, but what will really end the out-of-pocket in Africa is to see people not paying an upfront payment when they need care. They are looking for support. And that one will come only or mainly with the community-based health insurance program. If we have a strong community-based health insurance program, as it's the case in Rwanda, Rwanda managed to cut out of pocket by 88% by putting in place that. But this community health insurance program will be supported by, other incentives like, the saving we are doing with SWAP as the integrated planning process, like the digital payroll to stop with ghost workers. As we see in some countries, ghost workers, they represent more than 25 till 42%, like the study in DRC, showing that DRC is losing around $800 million every year on ghost workers. Like, the effort on domestic resource mobilization, we saw Ghana making effort. All of that will contribute to the community-based health insurance scheme. That will be the major way to have people out of pocket. About the Lusaka agenda, we have a minister who's with us here. He will be the right person to tell you why countries they need Lusaka agenda. You can imagine when you are minister, sometimes you don't know who are partners coming to you. Sometimes you don't know how much partners are providing. And second, you have many partners coming. It was in the past, it will not be again the case in the future, imposing countries to develop a specific plan for them. You will see an African minister sitting with so many plans, not talking to each other, and not really having a way to put them together. And this is the fragmentation we are talking about. But maybe Minister Dembi will tell us how he is moving with that. But just to say the Lusaka compliant, in G20 meeting last week, I challenged G20 ministers. I say, you cannot just continue to talk about Lusaka agenda without you asking partners who are getting money from you not to respect that. This is why we are moving from the concept just to advocate, to make it a little bit mandatory by saying, if, like Norway took the initiative by saying, if Norway gives money to Global Fund, to Gavi, to any other partner working for Africa, they have to show to Norway that they are Lusaka compliant. They are facilitating implementation for Lusaka under the leadership of the minister if they want to continue to get money. But over to the minister maybe for additional information.
Well, thank you very much, DG. I think this is an important phase in our lives. They usually say, if you don't have a plan, other people have a plan for you. I think what we're seeing now in Africa is a unified voice that we want to exercise sovereignty. We care about the health of our people. And so we want not only to garner domestic resources to exemplify that, but we want other people who come in to help to ensure that they are aligned with the country plan. So for us in Sierra Leone, we have what we call guiding principles that are enforceable. The guiding principles follow what we call the 4 A's. The first A is that we have a clear vision of where we want to go, and that's compliant with the Lusaka Accord. And so we're asking all of our partners, in fact, we're insisting that all of our partners accompany us if you want to help us. So you don't have to create a new vision. There's a national vision that's in place. You come and join and accompany us on that vision. The second A for us is to ensure that there's alignment. So we're all moving in the same direction. You're not having people come in and do things that are contrary to where we all go in a common vision. The third A is that we're in an accelerated mode where we're looking that people cannot wait. We want things to happen yesterday, and we are putting in place systems that will make sure that happens. The fourth A for us is mutual accountability. If you're holding me accountable for resources spent, I want you also to be held accountable for resources that are coming in the country. So the good thing about it is we haven't heard anybody complain about how bad this is, because this is common sense. This is what makes sense. I think the disruption, the financial headwinds that we're facing creates a real opportunity for us to get things right and do things better. So I think in terms of compliance, we have several models that are saying if you comply and you move towards the Lusaka agenda, everybody benefits. You see value for your investments, and the country also don't only respond to what the needs are, but they build the institutions that could assure sustainability. Over to you.
Margaret, over to you.
Thank you, Honorable Minister. We have the next question for you, our Honorable Minister. This question is on the remarkable strides made by Sierra Leone. The question is, Sierra Leone has made remarkable progress in controlling the Mpox outbreak. As you move towards declaring its end, what specific systems or strategies are being put in place to ensure rapid detection and containment of future outbreaks? And how will communities remain engaged in these efforts? Back to you, Honorable Minister.
So I don't want to be presumptuous, because we started with 2 cases. We ended up with 5,400 cases. We still have, as we speak, 4 cases. Fortunately, we know where these cases are. They're being managed, and we strongly believe that we are on the way to containing this outbreak. But for us, what we know is that we are really taking the opportunity. We have a new national public health agency here that is the institutional home for coordinating our prevention, preparedness, and response. At the same time, we have over 400 trained field epidemiologists who are deployed throughout the country. What we want to do is to have our health security posture built on a platform of primary health care. So within the primary health care, you have institutionalized the ability to look at data, the ability to interrogate data, the ability to have tripwires that will switch and see this is an unusual number of cases and trigger a response. Trigger a response such that you're able to not only have local analysis and local foot soldiers to respond, but you could quickly assemble on a national scale to be able to crush an epidemic before you have even other people coming in to join. So for us, the issue is, how do you maintain these systems that we've created during quiet times? You maintain the systems during quiet times by actively involving community healthcare workers, by actively involving civil society in the malaria programs, in the TB program, in the nutrition program, in the reproductive health programs. So you get them involved in daily primary healthcare activities, such that you build trust and confidence between you and the people that you serve. In the event of an outbreak, an unusual increase in the number of cases, you're able to detect it quicker, you're able to respond faster, you've built a trust and confidence in the community, and the community participates as active partners in responding to the outbreak. So I think we're using this to just strengthen our primary healthcare system during quiet times and have the surge capacity to respond when you need to. Over.
Thank you, Honorable Minister. Let's take the next two questions. I have a question here for both DG and for you, Honorable Minister. What's the plan for the continued fight for combating of AMR in the least developed countries, such as Sierra Leone, to be precise? Start with the Honorable Minister and then Kasea.
So AMR is vital to us. You don't only see the AMR consequences in actual individual patient care, but you also see the consequences of AMR on a broader scale, on a national program as well. So for us, the issues become, how do you ensure proper use of drugs and products? How do you ensure that they effectively used in the programs on the one hand, and that's on the prevention side, and at the same time have active surveillance and pharmacovigilance for products in general, and at the same time have strong regulatory systems that are looking at some of these products and having a much more rapid response. The other thing that's going on is at times you don't really detect these MRs until you have active surveys or active studies that are going on. What we're doing now is to invest on a national scale on looking at routine data collection. When you have routine data collected across all of these different entities, you're able to see unusual occurrences. You're able to detect or flag issues that will require additional studies. So we're investing in national data systems. We're investing in active surveillance. We're also investing in ensuring that programs are really effective. I mean, I see some people focusing on MDR-TB as a good example. Well, MDR-TB is there as a result of failure of the routine TB program. So we want to be able to strengthen the routine TB program as we focus on the MDR-TB. Similarly, in the malaria program, similarly we have broad antibiotic use again. So we're looking at a very scientific focus basis of looking at AMR with an emphasis on prevention, early detection, and response. Over.
DG?
Yes, to add on what the minister said, AMR is a silent outbreak. And we have some proxy, but we cannot say we really know the magnitude of this issue in Africa. Each country must conduct, as the minister said, serious studies. We need to build also capacities of lab to detect AMR. We know that only 3% of labs in Africa can perform that. This is not helpful. And we need also to discuss how vaccinating people is preventing AMR, because that one, it's one of the arguments that we are using to say we still need vaccines to avoid people to take antibiotics. But when we talk about antibiotics, we need also to know that Africa wants to manufacture our own antibiotics. A country like Egypt, for more than 90 or 95%, they are using their own antibiotics and they are fine. I think we can share that, and Egypt is ready to either export to other African countries or to also build, the partnerships with other countries. I think all of that, we need to have to continue to work on that, and the next AMR meeting will take place next year in Nigeria. Will take time, to reflect on that, the progress we made, and the way we are moving forward. Over, back to you.
Margaret, if I
you.
may just jump in there as well. I mean, an additional area for us is on the One Health platform. I think we're looking at veterinary use of a lot of these products. They're not as robust as what we're doing, the surveillance we have in the human use of products. But again, I think working with Ministry of Agriculture and the lab networks on the agriculture side, I think we'll be able to better understand and respond much, much quicker to AMR issues. Thank you. Over.
Thank you, Honorable Minister. Let's take the last two questions. I have one for the Minister and one for Dr. Kaseya. I'll start with the Minister question here that says, this is Mariam Ba, a journalist in Sierra Leone. The question is, Africa CDC has called for health sovereignty in Africa, but what does this mean in practical terms for Sierra Leone, and how close is Sierra Leone to achieving it? That's for you, Honorable Minister. And then the last question for Dr. Kaseya is from Ama Okoye, Dochowela Bureau Chief for West Africa. The question is, what would we be worried of health-wise currently in the region of West Africa? Are there any concerns health-wise for the West Africa region? I'll start with you, Honorable Minister, and then Dr. Kaseya.
So health sovereignty is having us be responsible for the health of our people, take primary responsibility for the health of our people. In the Sierra Leone context, what that means is having a clear vision for what we want to do in our country. Again, you could translate it into multiple thematic areas. So for example, we're saying we want 0 preventable maternal deaths. We want 0 preventable infant deaths. We want 0 zero-dose children in our country. For us, that's a starting point. Now you look at how do you achieve that? So it's financial, it's structural, it's governance, it's human resources, it's supply chain, it's a host of activities that you're working on, but you are in charge. You're directing. You're looking at what the domestic investment is. We'll be having about 11.4% of expenditure on health. We want to raise that to get to the Abuja numbers. We're looking at human resource. We're looking at supply chain. We're looking at building institutions that are able to do that. So it's a lot of these things that are going on. But as we started in this discussion, you don't wait for others to come and tell you what to do, how to do it, where to do it. The countries are taking a leadership now. And in this case of Sierra Leone, we're saying what we want to do for our own people. We will do what we are able to do from our own resources, but we're asking partners to join us and help us as we move in the direction that we want. That is sovereignty. That what will last forever, not close-ended projects that we've been used to, not disease-focused interventions that will be used to. We're looking at full-scale, human-centered approach that's looking at universal health coverage where everybody's health matters. And the government and the people are taking the lead for their own health. Over.
Yes, if I got it well, the question was, what are the major concerns that I see in the West African region in the public health area? I can say the first one would be the emerging and re-emerging infectious disease outbreaks. We are talking Mpox in Sierra Leone. We are talking about Lassa fever, in Nigeria, also other countries. And we have also the issue of other public health emergencies that can affect, like cholera, meningitis, viral hemorrhagic fevers. This one is the first area. The second one, I would say, the weak and underfunded health systems. It's really linked to what the minister is saying. This is why we are pushing for the health sovereignty and the Lusaka agenda to say we need to provide more resources, but we need mostly to fix our inefficiencies in the system. Ghost workers, procurement, sometimes with fraud and corruption, and lack of the digital agenda. That one is contributing to the weak and underfunded system, in addition to lack of domestic or not so sufficient domestic resources coming from countries. I can also talk about what we call the double burden: infectious diseases and non-communicable diseases. You see, today our ministers are facing these challenges where some partners are coming to say, I'm just supporting infectious diseases, not non-communicable diseases. But we need, as the minister said, one plan. Because even if this partner is supporting infectious diseases, maybe it's paying community health workers who are also supporting the non-communicable diseases. Maybe it's strengthening the lab. That also will support the non-communicable disease. It's just really under the one plan that we can also consider to move forward. I will also talk about the last one that can be the minister was talking about One Health, the climate challenge. We see malaria, chikungunya, dengue, these are waterborne diseases and vector-borne diseases. How can we manage that? By also bringing other partners, because we know 70% of outbreaks in Africa are zoonotic diseases. I think if we consider that, we can say in our area, these are mostly the main concerns that we can have for that region.
Thank you, DG. And with that, we have come to the end of our briefing this week. I will hand over the floor first to our Honorable Minister for any last words, and then we'll move on to Dr. Kaseya. Over to you, Honorable Minister.
Well, thank you very much, Margaret, and thanks to DG for hosting this meeting. I think one of the lessons that we're learning is the interaction between countries. One lesson learned from one country could be shared with other countries on this forum. We thank the Africa CDC for the direct support, technical, material, and actual funding for the response in Sierra Leone. And we look forward to working with others and sharing our experience so that what happened in Sierra Leone could be prevented in other countries as well. Again, thank you very much for the opportunity.
From my side, it's first to thank Minister. He's even attending a meeting in Dakar, but he dedicated time for this press conference. Thank you so much. Thank Minister for sharing with us, even if you want to continue to be cautiously optimistic, but we know based on evidence that Sierra Leone is making progress, and congratulations for that. And we hope to celebrate the end of this outbreak very soon. This press conference will discuss a number of issues, but what came strongly first, health security and sovereignty, how we are bringing this concept. I think next week, when the Lancet article will be out, we'll dedicate more time to that. We also discussed about how countries can start to share information, because today we are one continent. Even if we have so many countries, but we are one continent, we need to learn from each other, and especially in the context where our partners are coming to us. It's not just the US. We see World Bank coming requesting compact. We see EU coming requesting also another form, and most of our partners are coming. We need to start to share information to know what is our best interest in Africa. And we discuss also a number of other outbreaks. I think next week, maybe I will be joined by the Minister of Ethiopia to talk about the viral hemorrhagic fever in Ethiopia, and to see what will be the latest update he will give us. Thank you so much, Melissa and Margaret, and thank you also to our colleague journalists who joined us.
Yeah. Thank you, and bye.